First of all, I'd like to thank APAO and good morning, everybody. I'll be talking about failed macular hole, what to do. Giant macular hole is defined as base macular hole diameter more than 1000 microns with MLD of more than 800 microns. These holes have high rate of failure. Failure rate in macular hole of 650 to 1416 micrometer is somewhere between 19 to 24% in Manchester large macular hole study. Various strategies has been described to deal with failed macular hole, which involves inverted macular hole by Michael Visca, autologous ILM transplant, lens capsule transplant, neurosurgical retinal graft, amniotic membrane by Rizzo, retinotomy, and hydrodissection. I'll be talking about autologous ILM transplant, which I do, and I combine this with hydrodissection to deal with very large macular holes. So these are the management strategies for failed macular holes. And if you have an extra large macular hole, inverted flap, ILM autologous transplant with hydrodissection is my preferred choice. I don't prefer this retinal transplantation because I believe vision does not improve in these kind of patients once we do an autologous retinal transplantation. This is my first patient, relatively small hole. I did and went ahead and did an inverted flap in this technique. But you can see after 2 weeks of surgery, the macular hole is still open. The gas was still there, so I thought I'll ask the patient to lie down in prone position. But over a period of 4 weeks, you can see the macular hole is enlarged. I don't know, you can see the ILM flap here, you can see this small flap here. So according to me, I did everything right, but this hole failed. I took this patient for surgery and went ahead, restained this membrane, and with the help of a diamond dusted, I tried to find the edge of the flap which I have peeled earlier. So you can see I can find out the edge of the flap here. The flap is there, and actually what has happened here is the flap which I had made initially has stuck and caused a traction onto the retina. So since I get an ILM flap from my old flap, so I don't plan for an autologous ILM transplant. I go here, peel this, and it's important to bring this peel right till the edge of the macula. At this stage, many times I'm worried that I lose this ILM flap. So what I do, I put an PFCL so that I don't lose this ILM flap. Because if I lose this ILM attachment, then it becomes very difficult to put this ILM flap over the macular hole. Again, the ILM is brought right into the center and a flap is made and put it over the ILM, over the large macular hole. Once this is done, go ahead and do a fluid air exchange, and you can see this 2 weeks post-operative results. The hole is closed, and this patient improved by 2 line to 636. Saying it's very easy that you say you put an ILM flap into a macular hole, but it's extremely difficult, and these problems are highlighted in this video.
Has improved over the past years with the refinements in vitreoretinal surgeries. Closure of typical macular holes can be seen in over 90% of cases. However, non-closure can still be seen in some rarest of the rare cases. A variety of techniques have been described for managing failed macular holes like autologous retinal transplantation or amniotic membrane transplantation, but we still prefer using ILM grafts. It is easy said than done because resurgeries hold challenges at every step, so let's discuss about them. Challenge number 1: the wandering flap. In resurgeries, when we lift the ILM flap from a distant site, due to currents from continuous infusion, the transportation of flap becomes difficult. The fluidic turbulence leads to running amok of the flap. To avoid this, turn off the infusion Wait for the flap to stabilize and then repose it. Challenge number 2. Transporting the flap inside the PFCL bubble. While working under PFCL, if we lift the flap away from the retina, it sticks to the instrument. Once it gets stuck to the instrument, it becomes impossible to reposit it back. Challenge number 3. Flap sticking to diamond duster. On attempting to separate the flap from the diamond duster, it sticks to the forceps, again impossible to free it. Challenge number 4. Trying to introduce the flap inside the PFCL bubble. PFCL is immiscible with irrigating fluid and has got high internal surface tension. Thus, it gets difficult to introduce the flap from outside into the PFCL bubble. So what are the ideal ways to deal with these nuances or challenges? Begin with the basics. Stain good. Create a hinged flap with a blunted diamond duster, and after that pour ample amount of PFCL to cover it. This prevents the flap running amok and provides the needed counter traction. Roll the ILM flap under the PFCL to reach the hole without lifting the instrument. Take the help of chandelier illumination, do a PFCL exchange. At the same time, inject BBG stained viscoelastic substance over the flap. This prevents dislodgement of the flap. So with these techniques, we can face challenges in the resurgeries and finally seal the deal.
Now, with very large macular holes and failed macular hole, what I am doing is an hydrodissection technique of detaching the posterior pole of the macula. So, in this video, after you can see it's a huge macular hole with a base diameter of somewhere around 1800 microns, and we stain this. PFCL is put and an hinged flap is created nasally. Once this hinged flap, I use a diamond duster to bring it right into the center over the macular hole and put this flap into the macular hole as an ILM transplant. And once this is done, I go ahead and detach the posterior pole. It's important that you detach the margins of the macula, and you can see the fluid coming here. The idea basically is to make the posterior pole more elastic, so once the retina settles down after detachment, it closes. And you can see the post-operative result. The hole is nearly closed, and this patient improved to 624. This is another patient of very large macular hole, more than 1000 microns of base diameter. And a square-shaped ab, the chances of failure are pretty high. So we went ahead and did this macular detachment with ILM flap, and you can see this patient attained his vision of 612 with a good closure of macular hole. And with this technique, we have done 9 cases, and in almost all our cases, the vision has improved. Only one case, there was in type 2 closure, and the vision, but in that case also the vision improved to 636. So up to 39% of chronic macular holes and failed macular holes have been reported to have adhesions between the retina and the RP, contributing to difficulty with hole closure. This gives square edge appearance on OCT in contrast to the puckered edge seen in the acute macular hole. Advancement of macular tissue by increasing the elasticity of retina by ILM peeling, ILM scaffold over the macula because of the flap, and then doing a macular detachment and what we call as an hydrodissection of the macula results in improvement in our all our cases. The important thing here is if you go for a retinal transplant, then in most of the cases, although you can achieve an OCT closure of the macular hole, but the vision does not improve. With this technique, I am able to get at least 2 to 3 lines improvement in all my cases, and there is no metamorphosia post-operatively. The only drawback is I have done only 9 cases, but need more giant macular holes and failed macular holes to prove the efficacy of the technique. Thank you very much for your kind attention.
Nice presentation, Dr. Avnindra. I mean, the free ILM flap technique under PFCL is a fairly good technique to cover a large macular holes as well. I mean, do you really think this is necessary to combine hydrodissection along with free ILM flap?
Initially, I had it because it's a pretty large macular hole, and many a times you find adhesion. One of the traumatic macular hole, what I was doing somewhere around 2000 microns, and I found there was an attachment between the macula and the disc. So until unless you have some kind of tissue which can advance and close the retina, you will not achieve a closure in very large macular holes. So combining both the technique, I am able to get good results with good visual improvement.
Dr. Pralay?
So I want to ask the site of injection of BSS. That created some nerve fiber layer defect, very thin portion.
Initially, I had a concern about this. Creating a detachment, I did an OCT where I created a macular detachment, and post-operatively I couldn't find any defect there. It heals because it's in 40 gauge opening, it heals by itself. So, and patient also didn't complain of any field effects what I did afterwards. So initially I had a concern about this. To get rid, to clear my doubts, I did these 2 things, OCT, through the area where I have created a detachment, and fields I didn't had any problems post-operatively.
Dr. Subhendu, please.
Yes, I have a small suggestion. You are just covering the macular hole with the ILM flap, followed by you are dissecting doing the hydrodissection for the macular hole. Okay, but if you are doing it the reverse, like if you are dissecting the macular hole first and just make it smaller in size, then put the PFCL and do the ILM graft over the covering the macular hole, because after doing the flap covering the macular hole, you are dissecting this macular hole area. That means your flap can anyway go out during the aspirate.
Yeah, so in that case, what I have done, I have put viscoelastic, preferably Helon GV. So this was a concern because if you put an ILM flap in a fluid-filled eye, then it tends to get dislodged, what I showed in my video. So what I did was I put viscoelastic over it and then proceeded it for macular hydrodissection. But yes, we can do otherwise. Thank you for the suggestion.